Let's see. Let me just skip over that. This one, I'm sorry that it's hazy like that, but I need to show you this because you'll notice that this person scored above average in every cognitive domain. This was a 17-year-old admitted to our adolescent program. Her drug of choice was a hydrocarbon found in hairspray. She would sniff 2 cans of hairspray every single day. And this had gone on for more than a year before she came into our program. I didn't share those results with her. This illustrates what we call resiliency. That particular substance is one of the most toxic substances to the brain. Her brain was able to handle it in such a way that it resulted in no cognitive deficits whatsoever. Now, we'll talk more later about the balance between vulnerability and resiliency. What we try to do in treatment is build resiliency. So as our patients are exposed to stressors, here it was a toxin, but stressors that we deal with on a daily basis in normal life, as they become exposed to stressors, they are either, the response is either vulnerable or resilient. They were vulnerable in such a way that their brain changed when exposed to a substance, and they developed this neurologic thing we call addiction. I'll keep coming back to that concept. Let me skip ahead a little bit. All right. Yes, vulnerability and resiliency. Who develops addiction? It turns out that you could use cocaine every single day for a month and just stop and walk away from it and never use again, if you don't have the vulnerability. But if you do, you're not going to stop after that month. You're going to want more and more and more. You're going to develop tolerance. You're going to experience withdrawal when you stop using. You're going to have craving. You're going to have a preoccupation with the need to go find it and use it. You're going to stop experiencing any kind of pleasure from anything else in your life. You're going to give up all other function, and your primary goal from the time you wake up until the time you go to bed is to acquire that substance. Only if you have the vulnerable brain. In fact, of 100 people who regularly use substances, how many actually develop this disease we call addiction? What's your guess on average? That's right, 10%. 10% on average. If you look at the individual substances from alcohol, marijuana, cocaine, opiates, it varies between about 8 to 9% and 15%. The average is 10 to 11% of people. How is that possible? That means that about 90%, I'm not talking about 10% of the population. I'm talking about a subset of the population. Those who use substances on a regular basis, they never develop addiction. There are some people who can smoke marijuana every day and never develop a problem. I hate having to tell our patients that, but it's a reality, and we educate them. But I follow it up quickly with, you're not in that 10%. I mean, I'm sorry, you're not in that 90%. You are in that 10% because you're here. And why are you here? Because you used despite negative consequences. You used when you knew 10 o'clock in the morning that 3 o'clock in the afternoon you were seeing your probation officer and you chose to use cocaine at 10 o'clock in the morning. You're starting to see how the prefrontal cortex, that he wasn't able to predict the likely consequences of his choice. So that's impaired, right? Poor impulse control. By the way, the orbital frontal cortex, it's right above the eyes. So it's prefrontal is right here, right above the eyes, a little deeper, the orbital frontal. Orbital frontal cortex is responsible for putting the brakes on impulses. We all develop impulses, desires, cravings, wishes. The midbrain, deep part of the brain, it's constantly showering us with impulses. You're not aware of most of them because your orbital frontal cortex clamps down on them before they come into your awareness. I don't think it's helpful to say that a substance is or is not addictive. And I hope that you'll agree with me by the end of the lecture. I just told you that marijuana does not cause addiction in 90% of the people who use it on a regular basis. So what would it mean that marijuana is addictive? It's a meaningless statement, right? Now, the fact is that about 10 or 11% of people who use marijuana on a regular basis will begin to experience changes in their brain such that now the brain is in this state we call addiction. I want you to understand these concepts completely. The terms are often used loosely in the public and within the medical community. Doctors talk about drugs being addictive. The phrase doesn't mean anything. Go ahead.
For instance, I just take pizza. Pizza is not addictive, correct? I mean, can you be addicted to pizza?
I am.
I mean, the same
I'm going to answer the question.
Let's say you have two, marijuana and pizza. Are they the same?
We're finding that out. There's a very famous addiction psychiatrist, probably the most famous addiction psychiatrist in the world. His name is Dr. Mark Gold, and until he retired recently, he was the chairman of the Department of Psychiatry at the University of Florida in Gainesville. His research has changed throughout the years, moving on to different fields of interest. For a number of years now, he has been doing research to reveal whether or not there's such a thing as food addiction. He thinks the evidence is pretty clear now that, yes, in fact, there is. That is to say that some people who compulsively eat probably foods high in carbohydrates, actually bring about changes in their brain that are similar to those who develop alcohol dependence. So that's why there's real meaning to that question, pizza versus marijuana. He would say, yeah, equal in the vulnerable individual.
And all those factors are what determine whether you're vulnerable. Environment, biology.
Yes.
That's a great slide, by the way. I wish I had a copy of that. Because it really kind of makes a big picture very big in the history and all the way we can develop.
Right. So we're learning now that there are genes that probably create a vulnerability for someone to, if they become exposed to the right substance, go on to develop addiction.
Does it have to be a substance? Could it be an activity? I mean, some artists are very, very compulsive and can't do anything else, and their lives fall apart. I mean, just to use an example.
Well, you know, this is another fascinating area of research, and the example that comes to mind is what has been termed, at least in the lay literature, as internet addiction, right? You've heard of these kids spending hours and hours and hours on the internet. It's compulsive use. They may not really experience pleasure in response to any other activity. They may be continuing to stay on the internet despite negative consequences, like failing to go to school. Maybe their nutrition becomes impaired. But does all that end up translating into actual changes in the brain? That's the research that's being done. We don't know what the answer is yet. So, genes play a role. Let me give you an example of that. We have a natural opioid system in our brain. Now, the opiates are heroin, morphine, not in our brain, but giving an example of opiates. Morphine, heroin. Opioids are the synthetic opiates, like oxycodone, hydrocodone, or Vicodin. Right? Pain pills, in other words. The natural opiates in our brain, you've heard of them, endorphins, right? Now, we used to talk about things that give us pleasure, like exercise or running, will raise endorphins, and we get this euphoria or this rush. Turns out it's a little more complicated than that, but that's generally how you hear the word endorphins being used. The natural opiates. So endorphins attach themselves to a protein called the receptor, the opioid receptor. One in particular, a subtype called the mu opioid receptor. When you stimulate the mu opioid receptor, it results in pleasure or a lack of pain. We stimulate our own opiate receptors with endorphins. Well, there are genetic variations in producing that protein so that your opioid receptor may have a slightly different genetic blueprint than my opiate receptor. Well, there's one in particular, it's called the OPRM1 opioid receptor, that has been shown to attach to that endorphin a little too strongly, too readily, too quickly. It's almost too efficient. It turns out that that person with that particular variation of that opioid receptor is more vulnerable to developing alcohol dependence and opioid dependence. An example of how genes play a role in the production of addiction. The drug itself. Now, look, you may have every genetic vulnerability in the world to developing addiction, but if you never expose yourself to the substance, you'll never find out because you won't develop addiction. The environment. Chaotic home and abuse, parents' use and attitudes, peer influences, community attitudes, poor school achievement. It's obvious how these all play a role. Let me just give you an example of how the top one, though, may be translated into a biological effect. Remember the part of the brain responsible for memory? You all know, you just don't want to tell me. The hippocampus, thank you. The hippocampus. In addition to memory, the hippocampus is also involved in regulating mood. In fact, I'm going to give you a preview to the major depression lecture. When somebody develops major depression, the hippocampus, and we have one on each side. We have many brain structures where we have one on each side. When somebody develops major depression, the hippocampus on both sides shrinks. We think it's probably related to something called a glucocorticoid. It's a type of steroid that our body produces. Actually, our adrenal glands, which sit on top of our kidneys, release cortisol. It's part of the stress response system. We're experiencing some type of stressor. It's a way of sending a message throughout the body that we have to prepare to deal with the stressor. Well, the cortisol goes back to the brain. Essentially, it's like a thermostat to tell the brain, stop producing a different hormone that started the process. It's called corticotropin releasing hormone, or CRF. But in the vulnerable individual, the steroid will become toxic to the hippocampus, and the hippocampus shrinks. We see that in major depression. We also see that in another psychiatric illness called post-traumatic stress disorder. Slightly different mechanism, but related in terms of having shrunken hippocampi. Now we know that child abuse or neglect, emotional abuse or neglect, will affect that stress response system in an adverse way, making that individual vulnerable to the development of addiction later on, in addition to the vulnerability to major depression and vulnerability to PTSD. So it's a nice example of how something that's happening in the environment in childhood can actually change our brain and make us vulnerable as we're going through further development into adulthood. So genetic factors account for about 50%. The environmental factors also about 50%. All right, we talked about these different parts of the brain and the functions they subserve. We talked about the limbic system. Just a bit about brain communication. So now we're looking under a microscope. What do we see? What does it mean for the brain to function? Well, the brain consists of cells called neurons, lots of cells. In fact, how many people live in this world? I think we're closer to 8 billion people. Now, try to conceive of this. 8 billion people living in the world. Each one of us has approximately 100 billion neurons in our brain. I've known this for years and I still can't conceive of it. 100 billion neurons. Now, this is a typical rendition of a neuron, kind of the shape. This is called a cell body with the nucleus. The nucleus is kind of the brain of the cell. This is called an axon. These are dendrites. The dendrites are like branches on a tree. And there are many, many of them, enabling that neuron to receive information from other neurons. So each dendrite is receiving information from another neuron. One cell has one axon, so the information is coming in, the cell processes and sends the information to communicate with the other neuron through the axon. One axon for each neuron, 10,000 dendrites for each neuron. Picture a tree with the branches so that the trunk of the tree is the axon. Right where the trunk meets the branches, that's the body where the nucleus is, and all of the branches being the dendrites. 10,000 dendrites in a healthy neuron. If you look at somebody who suffers from addiction and count the dendrites, they have far fewer than 10,000. They've done damage to the neurons. That's what you're seeing in the PET scans and the functional MRIs of the activity. The loss of activity I showed you in the prefrontal cortex due to fewer dendrites. So there's less communication between the neurons. Yes, Ms. Portney.
When you stop using the drug, do these neurons come back to normal?
Yes. And there's something that we now know helps stimulate that process. But I'll get back to that. So the total number of connections going on in the brain? 100 billion times 10,000. Okay, now, we talked about the natural rewards. Those things that stimulate the nucleus accumbens. The release of dopamine in the nucleus accumbens. The release of dopamine by a neuron. Food, water, sex, nurturing, these are the natural rewards. These are just some examples of the drugs that create reward in the nucleus accumbens. However, drugs do it in a much more powerful way in that vulnerable individual. Another way of saying this, if we see on the left-hand side that being an axon of one neuron and this being a dendrite of the other neuron, now this neuron is about to communicate, is about to send a signal. And this is occurring in the nucleus accumbens. So this person has just eaten a great steak and has that sense of fulfillment, that sense of joy from eating that great steak. That joy is coming from this process right here. That neuron released dopamine, and it was picked up by this neuron, by the receptors, and turned on, creating the sensation that we are all familiar with. Now, what about drugs? This is what happens when that person becomes exposed to cocaine, for instance, or alcohol, or Vicodin, or Xanax. Much greater stimulation of the release of dopamine. This person cannot experience joy upon eating that steak. Not very much anyway. Or going to a good movie, or having a conversation with you. Now, another area of the brain now this is as if my head is oriented this way. So this is the prefrontal cortex. This is the eyeball, right? So you can orient yourself. Back of the brain. This is deeper. The midbrain. When we develop some type of desire, craving, wish, it's coming from deep in the brain. That initial drive. In the healthy brain, what happens is the message of that desire is sent to the prefrontal cortex. We become aware of it. I could really go for a banana split right now. And I start walking out the door. I didn't think about the likely consequence of what it would be like for me to experience in regard to you watching me walk out the door. You'd think that maybe I just had a stroke or something. There's something wrong with me. I'm leaving you in the middle of my lecture to go get a banana split. So I have to think about the likely consequences of leaving right now. But I have this desire for that split. I think about it. Well, let's stimulate my orbital frontal cortex. Puts the brakes on the craving. And I'm storing it in my hippocampus. I'm going to get one later, not now. Delayed gratification as opposed to immediate gratification. I'm able to do that because the message is going from where it developed to my prefrontal cortex. This area of the brain is called the ventral striatum. As the person is developing addiction, as the person is becoming compulsively exposed to the substance that's changing the brain, this pathway finds an alternate route. You know, that damn prefrontal cortex keeps getting in the way. It makes you think about the likely consequences. Who cares about the likely consequences? Just act. Well, the dorsal striatum that's a way of sending a message from where it develops straight up to the motor system. Move, act, behave, rather than going through the prefrontal cortex to think about it. We know now that in addiction, this pathway becomes stronger and this one is weaker. So now a desire, a craving, I feel like having a drink right now. Boom, right to my motor cortex. I'm out the door. You can't stop me. And you're think about what you're about to do. Well, that person can't think about it because that prefrontal cortex is not active enough to think about it. You see, we see that all the time. We'll be sitting in community, and every single person in the room knows what's going to happen 30 minutes after you leave this room. And the person who's determined to leave, no, you're all wrong. The prefrontal cortex is not getting the message. That the anterior, dorsal striatum is what is carrying the message to the part of the brain that's responsible for movement. You know, there's another illness that involves this particular part of the brain, the dorsal striatum, and that's called, and we'll talk a little bit more about it later on, that's called Obsessive-Compulsive Disorder. That person has this drive to repeat a behavior in order to regulate anxiety. I'm going to come back to this disease, but I just want to mention that it involves that dorsal striatum, the compulsivity, the compulsive nature to the behavior, because that part of the brain is active. From impulsivity to compulsivity. What's the effect? Reduced ability to experience pleasure to anything, depression, decreased motivation. Remember that tremendous release of dopamine into the nucleus accumbens. After a while, the neurons producing it can't keep up. And so there's essentially a relatively low level of dopamine being expressed, so that the person begins to develop dysphoria, depression. Nothing can elevate me. Except maybe more drug use. Push a little bit more dopamine into that nucleus accumbens. And so after a while, they're not using to just develop euphoria, they're using to try to create a normal sense of feeling.
Didn't you say in one of the lectures before that when you're getting on your loved one's case about that they might do something they shouldn't do, trying to put guilt on them, that actually causes them to release even more dopamine? I thought I heard that in one of your lectures before. And trying to play that role, making them feel guilty about their behavior.
I don't think so. Yeah. Just trying to think about whether I might have said something similar. Let me think. So we talk about the brain being hijacked by addiction as if possessed by the devil. Now I'm going to show you a graphic piece from a movie that I think depicts this process extremely well. And I think that because you know your loved one so well, it's hard to remind yourself that when that person is in active addiction, his or her brain is hijacked by a neurologic process so that it's not really him or her making these choices. It's the changed brain that's making the choices. And when you can really believe that, and I hope I'm convincing you of that, then it will change the way you interact with that individual. Certainly, you'll have more empathy, and you'll see that person being the victim to his or her illness. And I myself am reminded of this movie when I'm interacting with someone in active addiction, and they're being very hostile and aggressive toward me and just determined to keep their illness alive. And I'm batting that illness in the head as much as I can.
Dr. Klein.
Yes, I'm Dr. Klein. This is Dr. Tandy.
Sharon, things have gotten worse since I phoned you. I think you're going upstairs.
Is she having spasms again?
Yeah, but they've gotten violent.
Did you give her the medication I gave you?
Yes.
What was that? Where is he? Well, that was Ritalin.
Chris, doctors.
Mother,
McNeil, Dr. Tandy.
What is it? What's happening? Make it stop! It's burning! It's burning!
Do something, doctor. Please help her.
Please, Mother! We'll make it stop! He's trying to kill me! Mother! Make it...
All right, let's see what
Keep away! The sow is mine!
Fuck me!
Fuck me!
Fuck me!
Back!
Is that little girl making a choice to behave that way? You have no problem accepting that it's the devil inside of her. The devil has hijacked her brain and is using the body essentially and dictating everything. As you learn about addiction, you begin to see the person suffering from addiction in the same way. Knowing full well, you seem to be talking to the person you think you know, but it's really that person under the influence of addiction. And you begin to separate the two in a way that you will be most helpful to your loved one. And this is the crux of our job in helping you to recognize what's coming from the devil versus what's coming from your loved one, and to know how to respond. There's hope. We have treatment. Treatment in general combines medicines of various types with psychotherapy. We'll start with examples of medical treatment. In nicotine dependence, there are a number of different strategies. You've heard of some of them. Nicotine replacement therapy. Nicotine in itself doesn't really cause much harm. In fact, there's research being done to try to harness the benefits, and the benefits are probably involve cognitive enhancement. Nicotine stimulates a receptor called the acetylcholine receptor. It's involved in many functions of the brain, many cognitive functions, particularly memory. In Alzheimer's, the system that produces acetylcholine deteriorates. Therefore, you see memory impairment. So we'll probably be using forms or derivatives of nicotine in the future for cognitive enhancement. So that's not the problem in cigarette smoking. It's the cigarette smoke. The hundreds and hundreds of carcinogens, those cancer-causing agents, the carbon monoxide, the tar, all of that stuff. So if we can deliver the nicotine in a relatively healthy way, we reduce harm by getting rid of all the other stuff. We're still maintaining the nicotine dependence, but in a much healthier way. Now, many people who try different forms of nicotine replacement, patches, lozenges, etc., find that they don't work. Studies have shown that often they're not working because the person is not achieving the same level of nicotine that he was with the cigarettes. So, by the way, in the person who has become dependent on nicotine, they become tolerant to such a degree that now a certain level of nicotine is required before that person begins to experience discomfort, which we would call withdrawal. So after a certain amount of time after a cigarette, the nicotine level begins to drop. Once it gets to a certain level that's unique to that individual experiences craving for another cigarette. That's just another way of the brain saying, uh-oh, I'm used to a nicotine level like this, and it's dropped here, so I have to produce a sensation in you that will get you to raise the nicotine level. And the person smokes again. Nicotine level goes up. You see? You think if you're dependent on nicotine, you think you're making a choice to smoke that next cigarette. The craving has been created by your brain to replenish the nicotine level. That's how that system has been hijacked. So, if you can maintain the same nicotine level with the replacement, then that person won't experience craving. So sometimes an individual has to have 2 patches on, 3 patches on, whatever it takes to maintain that level. Studies have shown that the combination of patch and lozenge are best at maintaining a high nicotine level. And we also see that that is often effective in our population.
What about the vapes? They're becoming so popular.
Yes.
I don't know about around here in Seattle, but they're all over the
In here too, the vapes. right? The e-cigarettes. We don't have enough research to support them completely. Intuitively, it would seem that the vaporizers are healthier than the cigarettes because you're not providing all of those carcinogens, tar and such. But there's some concerns that it's making it easier for adolescents to become dependent on nicotine, for example. What we're seeing is that people are replacing the cartridges with those containing things like hash oil. And so we don't have enough studies that firmly suggest that we should be recommending them. Many of the patients in the program used them. We're allowing it because so far there hasn't been strong evidence that it's more dangerous than smoking cigarettes. The jury's still out, but there is research being done looking at them. Now, the other mechanisms include providing medicine that may decrease craving for nicotine dependence. It was found by happenstance, actually, that people treated for major depression with the antidepressant Wellbutrin, or bupropion is the generic, that they were reporting less desire to smoke. They weren't putting an effort into quitting. They just didn't feel like smoking any. So the pharmaceutical companies jumped on this and started doing research, and were able to show that, in fact, the people who used Wellbutrin, who weren't necessarily suffering from major depression, found that they were more likely to quit smoking cigarettes than those on a placebo. And so it was repackaged as Zyban, and now has the FDA approval for nicotine dependence treatment. Chantix is, or varenicline is the generic, is interesting in that it stimulates that nicotinic receptor, similar to nicotine, but only to a partial degree, enough to satisfy craving, but not overly so to bring about tolerance. It is the most effective treatment for helping people to quit smoking, but it only has, I think, about a 30% success rate over the course of a year. Yes?
Hi, when you said lozenge, did you mean the Zyban?
No, I meant a nicotine lozenge. Yeah. In alcohol dependence, we have a number of medicines with different mechanisms. Antabuse is something that creates a very distressing physical reaction if the person's taking the medicine and drinks alcohol. So you make the person aware, look, if you have a drink, then you're going to experience severe nausea, vomiting, dizziness, flushingness. You could even die. It could be that severe. Rare, very rare, but it could be. So the hope is that it's extra incentive to think twice about drinking. The problem is that it requires the person to take a pill every day, and if you think you're going to plan on drinking that day, you're not going to take the pill. And so it doesn't work. If you have a very highly motivated person, I cannot drink because I will lose my job, and you have a very equally motivated partner who's there from the time you wake up till the time you go to bed, or at least when you wake up and when you go to bed, then you can agree, for instance, to have the partner provide the support in ensuring that you take that pill practically before your feet hit the floor. So you don't even have time to think about maybe allowing yourself to drink that day. And then knowing that you have the pill in you will help you create that distance. And it does happen for a small percentage of people. I mentioned the mu opioid receptor earlier, in that we have variations, and one seems to increase the risk for developing alcohol dependence and opioid dependence. Why alcohol and opiates? Well, it turns out alcohol stimulates that opioid receptor also. So what if we blocked that opioid receptor? So when it becomes exposed to alcohol, it doesn't create any pleasure. That's how it happens. Naltrexone blocks that opioid receptor. The person drinks, didn't do anything for me. I'm not even finishing the glass. It's very effective. Not 100%, but significantly enough that anyone with alcohol dependence needs to be offered naltrexone as a component to their treatment. Campril is another medicine that has been shown to decrease craving for alcohol, has a different mechanism of action. It works through a different neurotransmitter. Zofran was a medicine that was developed to treat severe nausea and vomiting related to chemotherapy. When it first came out, it was extremely expensive. So the insurance companies would only cover it for those very specific clinical situations where people were undergoing chemotherapy. Then it came off patent and it dropped significantly so that we could use it for nausea related to anything. Well, there's a particular, alcohol has many, many effects in the brain. And so that's why different medicines with different actions can help decrease craving. There's a type of serotonin receptor in the brain. You may have heard of serotonin being increased by antidepressants, right, and decreased in major depression. That's a very simplistic view, but serotonin is involved in mood disorders. There's a particular type of serotonin receptor that is stimulated by alcohol. That also leads to pleasure. So, yes?
How are serotonin and dopamine different?
They're both neurotransmitters, so they're both molecules that are involved in communication between one neuron and the other. You find dopamine in certain parts of the brain, serotonin in certain parts of the brain, but also overlapping with dopamine. Some of the other neurotransmitters, I mentioned acetylcholine, also norepinephrine, gamma-aminobutyric acid, glutamate. They're all different examples of neurotransmitters, those molecules that are transmitted from one neuron to another. And you see different concentrations of different neurotransmitters throughout different parts of the brain. There's a medicine, ondansetron, or Zofran, that blocks that serotonin receptor, so then when that person becomes exposed to alcohol, there's no pleasure, decreased craving. Topamax was developed as an anticonvulsant medicine that has been shown to decrease craving. Neurontin is also an anticonvulsant used for many things. Actually, it's very well tolerated medicine. We use it in addition to seizures. We use it to treat general anxiety related to many things, not a specific anxiety disorder. Recent studies show for some people that this can markedly decrease craving. So we use it a lot in our program. Opioid dependence. That mu opioid receptor. All of the opiates of abuse stimulate that mu opioid receptor fully. Methadone also stimulates that mu opioid receptor fully. Suppose instead of the person injecting heroin every day, risk of overdose, risk of transmitting hepatitis C virus, hepatitis B, HIV, stealing, breaking the law in other ways, stealing from you, breaking into cars, etc., etc. Suppose we could just say, look, let's give you something to fully stimulate your opioid receptor that will prevent you from having to engage in all of that unhealthy behavior. It's methadone. The problem is, it's a full-acting opioid, which can be abused, has monetary value, would get sold on the street if it's not controlled. So in this country, there are laws in place that demand that the individual receiving methadone has to go to a federally licensed clinic to receive the dose of methadone every day. After a number of months, then that person can be trusted with a weekend dose, for example, and then it can increase a little bit more. But that's it. Now, it's not really fixing the opioid dependence, but it's reducing harm. As opposed to buprenorphine, Suboxone is the brand. Subutex, you'll also hear that word, is a brand of buprenorphine. The difference is between Subutex and Suboxone. Suboxone has, in addition to buprenorphine, this other substance called naloxone. I mentioned naltrexone earlier. Naltrexone blocks the opioid receptor. That's the oral version. Naloxone is the injectable version. It gets a little complicated, but I want you to understand this because many of your loved ones are on Suboxone. Well, drug addicts love to inject. If it makes me feel good when I swallow it, I'm sure it'll make me feel better when I inject it. They all learn very quickly that things get to the brain faster by injecting. And the faster something gets to the brain, the higher someone feels. Now, if you ingest naloxone, it doesn't get absorbed. So it doesn't block the opioid receptor. If you inject it, it goes right into the brain and blocks the opioid receptor. So when Suboxone was first released, of course, the curious addict wanted to know if he could get high off of that buprenorphine. So inject the Suboxone. But the naloxone would block the receptor before it could be stimulated, and the addict would say, no effect, not going to do that anymore. Ingenious on the part of the pharmaceutical company. Decreases the likelihood of injecting. Doesn't get absorbed any other way. So it's only there to deter injection. Now the way Suboxone is taken is sublingually. So it's a little film, comes in a pill form as well, tablet form, but it comes in a little film that dissolves very quickly under the tongue. The buprenorphine gets absorbed through the blood vessels under the tongue relatively quickly, less than 5 minutes. The naloxone doesn't get absorbed, just stays in the saliva, gets swallowed, does nothing. Buprenorphine, go ahead.
Aren't there some people that are immune to Suboxone that it does not work for them?
Those are two different questions. To be immune to something means that you have antibodies that will attack it and it won't have an effect on you. There are probably some people who continue to experience craving for opiates on Suboxone, even with the maximal dose. I haven't met one yet. And I've been prescribing Suboxone since it was first released in the end of 2002. But there are new people I meet every day, so I don't know. That person might come along.
Because I know somebody who says Suboxone doesn't work for her, so she takes the methadone.
It's quite possible.
But she's never going to be able to get over her addiction.
I'm hoping I'm teaching you that there are many components to treating addiction and not just medicine. But the medicine is playing a very valuable role. Let me expand on that a little bit. Whereas methadone and all the other opiates are full agonists, meaning fully stimulating that opioid receptor, buprenorphine is a partial agonist. Makes it a world of difference. First of all, because it's only partially stimulating the receptor, the individual is much less likely to experience euphoria, even if he abuses it. By being a partial stimulant at the receptor, partial agonist, it helps to rebalance the opioid system. in those parts of the brain where the opioid system has been damaged, then it's providing the stimulation of that receptor. In other parts of the brain where the balance may be off and there's too much of the natural opiate, endorphins, then buprenorphine may be able to compete and create a relative decrease in opiate function. So it's rebalancing the opiate system in the brain. Recent evidence showed that, remember I told you on that neuron with the 10,000 dendrites that there are fewer in those people who have developed addiction? There's evidence that buprenorphine stimulates the regrowth of those dendrites. So not only is it a reversible process, but now we have a medicine that actually has been shown to reverse that process. What do we see clinically? We see improvement in brain function. We see better impulse control, better mood regulation, better anxiety tolerance, better judgment, better executive function. Right? Because there's better communication between the neurons. You're going to communicate better when there are 10,000 dendrites than when there are 6,000. Now, I'm exaggerating that effect just a little bit to make a point. We don't have the proof yet that because it looks like buprenorphine can stimulate the regrowth of the dendrites, that this is necessarily translating into improved brain function. I'm hypothesizing that. Let me just mention naltrexone again before coming back to Suboxone. Naltrexone, remember, blocks the opioid receptor. So the thinking is that when someone first comes into treatment with opioid dependence, we detox them, that is, medically stabilize the withdrawal. We could use methadone, we could use Suboxone, helping them over the course of a week, getting them off of whatever opiate they were using. Now they're opiate free. Now, take naltrexone going forward, which in and of itself has been shown to decrease craving somewhat, nowhere near as strongly as the other two, but can decrease craving somewhat, and then also block any opiate that individual may choose to use. I have a craving for heroin. I inject the heroin, it does nothing, because the naltrexone is blocking the receptor. The initial studies looking at that revealed, well, that doesn't really work because the person who wants to use doesn't take the naltrexone that day, just like the antabuse, remember? But now there is an injectable form that lasts a whole month. So a person can get an injection and they're good for a month. They're blocked. They don't even bother trying to get high. Doesn't have any effect. But if that craving is there, at the end of the month, they don't return to the clinic for the next injection. They just use instead. There's research looking at which treatment is most appropriate for which patient. Because in general, there's in any medical illness, we don't really have one treatment that works for everybody. Many of you are probably on antihypertensive medicines, right? I am. I take one for my blood pressure. I bet you don't take the same one I do. There are many of them. And some work for me, some don't. Same with any of you taking them, et cetera, all the other medical treatments. Buprenorphine or Suboxone in South Florida is controversial. I have a bit of a reputation, actually, that makes me infamous. The rumor, I've heard a number of them, but one has been that I put every single one of my patients on Suboxone. Doesn't matter what your problem is. Another has been, I put my patients with opiate dependence on Suboxone because it forces them to stay in treatment, and I can keep them a long time and earn a lot of money from the insurance companies. I've been called a quack because I'm keeping drug addicts on a medicine that prevents them from being able to say that they're clean. In fact, we've had patients here who have worked with sponsors in their 12-step program who have told them, I'll continue to work with you, but you cannot consider yourself clean until you're off the Suboxone. It's a lot of ignorance. As a matter of fact, I was just thinking about Brittany. It all comes from a lack of knowledge. Not knowing about addiction in the brain, how addiction changes the brain, or the substance in that vulnerable person changes the brain in such a way that we now call this disease addiction. How opiates change the brain, what that means for the person who's become dependent on opiates, and what a medicine like buprenorphine can do. Now you know that it helps to repair the brain. Why on earth would you take that away from somebody whose brain is trying to be repaired? It makes no sense whatsoever. But does it also mean, conversely, that someone gets put on Suboxone for opiate dependence and then has to stay on it forever? No, that's just as naive. How long, though? Well, to answer that question, we have to do what we do to answer any question in the field of medicine. Do research studies. Find out. Every single medical procedure we do today for any illness is based on research studies. What have the studies shown? In 2002, when the handful of us started prescribing Suboxone, we thought, wow, this new medicine, it's a partial agonist, it'll help treat the withdrawal, might take a week or so, get them off of it, let them stay in and rehabilitate, work in a 12-step program, move on with their life. Great. 2003, 2004, 2005, we're all talking to each other. How's it doing in your practice? Not too well. Relapse, 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 relapse. Relapse rates are through the roof. It's not doing what it was supposed to do. What's wrong? Maybe people need to stay on it for a longer period of time. We're arbitrarily saying a week. What's so magical about a week? Maybe people need to stay on it for 2 weeks. Studies were done. 4 weeks, 3 months, 6 months, a year, 2 years, now 5 years. The studies have consistently shown that people who don't stay on it are more likely to relapse. Now, that still doesn't tell us how long they should stay on it. I'll show you the studies in a minute, but the bottom line is that they consistently show that the people who are detoxed using Suboxone for a week and taken off of it, when you look at that same population 3 months later, 85 to 90% of them have relapsed. That continues over the year. If you look at them over a year's time, 90%, study after study after study, 90% have relapsed.